I'm Dr. Rajesh Patil. I'm a consultant hematologist at MGM Vashi, and we are here today to discuss regarding some important aspect of bone marrow transplant or hematopoietic stem cell transplant in various kind of blood disorders. For this discussion, we have two eminent hematologists as our faculty, Dr. Naveed Tamboli and Dr. Govind Kendre. So, Dr. Naveed, what is exactly a bone marrow transplant?
So this bone marrow transplant, which is also called as a stem cell transplant, in this, the defective marrow of the patient, which may be because of some blood cancers or maybe because of some immune system defect, this bone marrow is destroyed by a conditioning chemotherapy, so that this entire bone marrow is destroyed, and this bone marrow is replaced by healthy stem cells from a donor, so that the defective marrow is being replaced by a healthy marrow.
Right. So it is transplant, it is a replacement of the defective bone marrow or defective immune system by healthy cells after giving some conditioning chemotherapy. So next question for Dr. Govind. So what are the different types of this bone marrow transplants?
Basically, there are two types of transplant. One is called as allogenic transplant and other is called as autologous transplant. In allogenic transplant, there is a donor whose healthy stem cells are given to patient, while in autologous transplant, patient's own stem cells are given back to patient.
Right. So can you little bit elaborate on what is the process of this autologous stem cell transplant?
So basically, autologous transplant is done for lymphomas or multiple myeloma or some immune disorders. Herein, first aim is to bring disease in remission, and then patient stem cells are collected, and then patient is again given high dose chemotherapy so that his bone marrow is empty and he can receive stem cells which we had collected previously. So these stem cells are given back to patient, and within 2 weeks these stem cells again regrow and populate the bone marrow, and then patient recovers.
So Dr. Naveed, can you tell how allogenic transplant procedure will be different from autologous one?
So in allogenic transplant, the process is similar to an autologous transplant. The only difference over here is in allogenic transplant, we collect the stem cells from a healthy donor. Thus, simultaneously, we give conditioning chemotherapy to the patient, so that his marrow is destroyed and space is created for these healthy stem cells to go over there. And these healthy stem cells then destroys if there is remaining cancer cells, that these healthy cells can also destroy that. So this process is called as an allogenic transplant.
Right. So in autologous stem cell transplant, the purpose is to deliver a high dose chemotherapy and to rescue the stem cells are given. While in allogenic transplant, the purpose is to repopulate the bone marrow of patient with the healthy cells of the donor and repopulates its immune system, which might take care of the further relapse of leukemia or other disorders in the patient. So coming to the next question for Dr. Govind, what are the different indications of these autologous stem cell transplants?
So basically, autologous transplant is done for various diseases such as multiple myeloma, Hodgkin and non-Hodgkin lymphomas, and there are some immune disorders such as systemic sclerosis, and for some solid malignancies such as neuroblastoma or ovarian tumor.
Right. And Dr. Naveed, what are the various allogenic transplant indications?
So in allogenic transplant, we can divide it into two parts. One is for the malignant disorders and one is for the non-malignant disorders. So in malignant disorders, the patients who have AML, ALL, MDS, CLL, some lymphomas which have relapsed after autologous transplant, myeloproliferative neoplasm. So all this comes into the indication for the allogenic transplant in the malignant conditions. Whereas for the non-malignant conditions, we do allogenic transplant for bone marrow failures like aplastic anemia, PNH, Fanconi's anemia, Diamond-Blackfan syndrome, and some inborn errors of metabolism also.
Right. So autologous transplants are very commonly performed for myeloma and lymphomas in adults, while they are commonly performed for neuroblastomas in pediatric population. While allogenic stem cell transplants are required for all relapsed hematological malignancies, and it is required for various kind of bone marrow failures, which also commonly present in the pediatric population. So, Dr. Govind, how you will decide to take a donor? what are the factors important in choosing the donor, what we can say?
Okay, so basically donor is required for allogenic transplant, and this donor is selected on the basis of HLA antigens present on the cells of the patient and donor. So we have to have these HLA type of proteins fully matched or somewhat matched, so that we can select the donor. Ideally we should have 10 by 10 HLA match, that is called as full donor match, or we can have a half match, that is called haplo match.
Right. So HLAs are the unique genetic signature or immunological signature of the every person, and we get HLAs. We get half of the HLAs from each parents, and we require to have a best match is the full 10 by 10 match. But if the 10 by 10 match is not available, then we generally can go for the half match donors. So, Dr. Naveed, what are the different donors can be available for allogenic transplants?
So for allogenic transplant, as we have said, the donor can be a full match. Full match donors are normally your siblings. So as I have for a patient who have received half gene from his parents, one father and one from mother. Similarly, his sibling might have received one gene from his father and one gene from his mother. So the probability of a sibling having a match is 25%. So there is a 25% chance that a sibling might be a full match. And if you are not getting a sibling that is a full match, so you can go for an haplo match. So haplo match we consider as any match that is more than 50% of the genes that are matched. So these are called as a haplo match. And if you are not getting any match or a full match donor, we go for a donor registry search. So there are many voluntary donors who can donate stem cells voluntarily. So we have registries that have their HLA genes over there. So we can match them, and that is called as a match unrelated donor transplant.
So for the search for the donor starts from the home. So what we look for in the brothers and sisters, because they are also the one who can have the same information received from their parents. So 25% chances of match is there in brothers and sisters, and 3% match can be even found in parents. And if we not get full match in family, we can look into the unrelated donor registries to get another full match donor. And if it is still not available, then we can choose the option of half match donors. Dr. Govind, can you explain us how these stem cells are collected?
So basically stem cells can be collected from three sources. One is bone marrow, another is peripheral blood, and third one, which is less popular nowadays, is umbilical cord.
So Dr. Naveed, what exactly we do in bone marrow harvest?
So in bone marrow harvest, so as you know, the stem cells are normally in your bone marrow. So the only way to collect the stem cells can be, if it is from the bone marrow, you have to do a bone marrow procedure. So it is normally done in an OT. A patient is given an anesthesia, and the cells are collected from the bone marrow.
So in the bone marrow harvest, generally from the back area, which is known as a posterior superior iliac spine, we take multiple pricks and take out the around a good amount of the bone marrow aspirate, and which is later filtered and transfused to the donor. So next question to Dr. Govind. Dr. Govind, what is peripheral blood stem cell harvest?
Basically, there is a apheresis machine through which one port is attached to the donor, and through which stem cells or the blood flows through the machine, and the machine separates its stem cells, and through another port the remaining cells or the other blood components are returned back to the patients.
Right. So the apheresis machine are more or less similar like what we see commonly a dialysis machine, where then from one end blood goes into the system, then they do apheresis, take out stem cells, and the remaining part goes back to the patient or donor. So there is third source is also known as umbilical cord source, like which we know, which is collected at the time of the birth, but the amount is actually very low, and it is not commonly favored because of the long time it takes for engraftment and the low dose of the stem cells. So there is always one question regarding the cryopreservation or the storage of the stem cell, commonly in autologous transplant. So what is exactly cryopreservation, Dr. Naveed?
So from the word you can realize it's a cryo and it's a preservation. Cryo means something very cold, chilled out, and preservation is to preserve a cell. So what we do in a stem cell, we use some chemicals like DMSO. So when that is added to the cells and it is stored at very low temperature, so these cells are in a frozen state where they use very less of energy and they are not destroyed. So this is called as a cryopreservation.
Right. So cryopreservation is the method to keep the stem cells for a long time. As such, we cannot keep stem cells more than for 3 to 4 days. But if we store them at very low temperature, like minus 80 degree or minus 140 in liquid nitrogen, the stem cells can be kept for years. And the DMSO, like Dr. Naveed has rightly pointed, is the agent which protects the stem cell when they are at such low temperature. Dr. Govind, what are the different type of conditioning chemotherapies?
So basically, there are two types of conditioning we give. One is called myeloablative conditioning. The purpose of this therapy is to clear the space in the bone marrow and as well as clear the disease. While another type is non-myeloablative, or we can call it as immune ablation. The purpose of it is to suppress immunity of the patient to reduce the graft rejection later on.
Depending on the general status of the patient, depending on his disease control, the therapy can be heavy. If the therapy is heavy, it is, we can say in simple language, then it is a myeloablative therapy which might have more toxic effect, and non-myeloablative where the dose is relatively low. And how to decide it depends on how much is the disease already controlled and how much is the general status of the patient. Dr. Naveed, what is the in general course of the bone marrow transplant?
So once the stem cells are given to the patient, so these stem cells, they by a process called as homing. Homing is a process where they have a tendency to go into the marrow. So even if the stem cells are given to the peripheral blood, they go to the marrow. And once they are into the marrow, they start proliferating. But as we have given conditioning chemotherapy and there's a time required for these stem cells to proliferate and start building up, there is a span of neutropenia, and where your WBC count will be low, your platelets will be low, your hemoglobin will be low. So this is a time where your course is a bit difficult, where you can have neutropenia, where you can have infection. But once these stem cells start proliferating, they start building up and they start producing neutrophils, platelets and hemoglobin. So this process is called as engraftment.
Right.
So once we get the stem cells, then the effect of conditioning generally starts. By that time, patient WBC counts go very low. Patient can have fever. Patient can have mucositis, which can manifest as the throat pain. There can be loose motions, and there are various kind of complications can be possible during transplant, which can include a trauma to the liver, or mild damage to the kidney, and seizures. Depending on what kind of conditioning agent is used, what are the comorbidities patient can have. And after generally 2 to 3 weeks, the homing is done and the donor cells repopulate the marrow, and most of the complications are improved by that time. Once the stem cells are engrafted, what are the complications we can expect in the patient?
So basically, one of the major complication which can we think of is graft versus host disease. It is basically grafts or the donors cells attack patients' other healthy cells. So that it can be two types. One is called acute GVHD, and when it happens after 100 days of the transplant, it is called chronic GVHD. And it can affect your skin, liver, or the gastrointestinal tract.
Right. So GVHD name itself is graft versus host disease. So whatever stem cells of the donor which are in the patient's body, when they are engrafted, they sometimes find that this body is foreign to them, and then they launch an attack on the recipient normal cells, like as Dr. Govind has pointed, which can cause a skin rash, which can cause jaundice, which can cause loose motions, and in medical terminology, it is an acute GVHD. While after long days, maybe after 3 to 6 months later, they can have a fibrotic manifestation where there can be slow damage to the skin, there can be damage to liver or lung, and this manifestation will be called as a chronic GVHDs. So various kind of immune suppressant agents are used to treat this kind of GVHDs. So Dr. Dr. Naveed, so suppose we have done a transplant and now patient is around maybe a 1 year post-transplant. Can you tell us what are the late complications can happen in a patient after stem cell transplant?
Yes, late complications are known to happen in bone marrow transplant since because we are using some conditioning regimens that are also very toxic, and these regimens can itself lead to secondary malignancies, solid tumors, which can happen months and years after the transplant. And one more thing is that once we have done a transplant, there is a very late possibility of having bacterial and viral infections later on in the part of the life.
So once most of the patients they are after 1 year or 2 years after transplant, depending on the complications they had during transplants, their life changes accordingly. Those who have chronic GVHDs persistently, they might have more chances of getting infections, as Dr. Navid has pointed. While those who have received the heavy chemotherapies, there might be a rare chance of developing another secondary malignancies after few years. So because of chances of getting late infections, these patients have given vaccination, killed vaccination, which is generally given 6 to 1 years after transplant, while live vaccines are given after 2 years of transplant. Coming to Dr. Govind, can you tell us what are the general chances of success in various kind of disorders in stem cell transplant? So when the patient relatives approach you and say, my patient is benign thalassemia or aplastic anemia, what are the chances of success in this transplant? So what are the chances of success? You explain them.
So, in benign disorders such as thalassemia or aplastic anemia, the survival chances are around 80 to 90% of successful outcome. While in malignant disorders, around 50 to 70% chances are there that the transplant outcome will be favorable.
The chances are relatively low in malignancy because the malignancy can even relapse even after doing a transplant, and relapse can happen as early as first 1 to 2 months to as early as first 5 years. So in general, like as we have come to know that many relapsed malignancies and various benign disorders are cured by the stem cell transplant. So those who are deserving candidates should visit the nearby transplant centers to avail the benefit of these transplant procedures and transplant facility.